Oh, now I have to be careful what I say. Hi, Vanessa. This is the bad part. People sign in. I just like call people out randomly to say hi to them. I'm excited about today's talk. I'll do a little bit of an intro to it, um, and then introduce the Melissa. And just so you know, too, and Andrea, I usually let the speakers do most of their own introduction, so I'll just kind of say your name and then pass it right over to you. But and I think you should have, yeah, Angela's already made you guys co-hosts, so you should have you can be able to control your stuff. So
Sounds great.
yeah. Well, happy June, everybody. We'll give it just another minute or two. Our listserv for idea is about to hit the 800 mark, so that's cool. Yeah, so a lot of people are using it for lots of good reasons. And what I find, a lot of people are actually accessing our recordings that we're putting on our website. All these are recorded, as you can see, and a lot of people are going back and using them. So I always offer this too. Like, I've been pretty selfish with topics, have been for a couple of years now. If there's a topic that someone really wants to put out there to talk about that we can invite a speaker to, feel free to back channel, email myself or Angela, and we'll keep a list of those topics and make sure we always try to get like a really good speakers who are knowledgeable in that area. Oftentimes it's also people who we may not have heard of that are good speakers or have a big content knowledge as well. So I'm excited about next month. So William Mandy, who's I don't know if you guys know who he is. He's a pretty well-known researcher in the UK. And I've seen him talk. He's a great speaker on a range of topics. He's been in the field for a while. So we convinced him to come talk to us. I gave him a choice of what he wants to come talk to us about. Hi, Elizabeth. And he is going to talk about eating disorders of autistic women. So he's done a bunch of research and has some interesting results to share with us on eating disorders in autistic women, which I thought would be very interesting for us and relevant as well. Not a topic that we often have talked about or dealt with. So, and he's just great as a speaker and as a researcher. So I'm excited to hear him. After that, I have some ideas for the month August and September and October, but nothing is locked in at this point. So again, if you guys have any ideas for topics that you'd like me to address or invite speakers in, feel free to put them out to either myself or Angela. You can don't type in the chat though, because those are hard for us to record. So Angela put her email address in there. So just go ahead and forward her an email if you will. Thank you for that. All right, so we got about 50 people on. That's usually a good starting point. So I just want to give a really brief introduction as to why I invited Family Navigation people here and having Melissa and Emily and Andrea come speak with us. Everywhere I've been in terms of running a center or addressing autism, I've always been impressed with the need for us to do stuff for the families after we give them the diagnosis. So, like one of the terms from when I was in Missouri that a neurologist said I'll never forget is the worst thing you do is diagnose and adios. It's like, yeah, here's your diagnosis. Good job. Good luck out there in the world. And I'm always struck by, and we've all dealt with this, when we're doing our feedbacks and we're working with the families, just the multitude of questions that they have and the look of complete, on many of them, of shock, dismay, confusion, just being totally overwhelmed. The research supports and my own anecdotal experiences support that once they hear the diagnosis, they stop listening. So, they're so overwhelmed. They don't, studies have shown they don't really remember or hear anything after you've delivered the diagnosis, right? So, we started implementing in our own centers a way, some type of support afterwards to give the families. And there's many different models for this and how you might do this. A lot of the times, quite honestly, this has fallen on the provider themselves, the psychologist, to say, okay, here are my recommendations. Maybe I'll meet with you in a week from now or a month from now, or even now, like here's some papers to give you and here's some resources to give you. And if you've ever been on the other side of that, it's overwhelming because you walk away with a diagnosis and a stack this big of papers that you probably most people don't ever read. And then you have to learn to navigate what is autism, what is, if it's intellectual disability, what is SSI, what is an IEP, what is a 504. There's all these things that they have to navigate, and they're completely and utterly overwhelmed. So we started using, and there's different names for them, but patient navigation, family navigation, patient or family support networks. And for what we found to be really helpful for us is it takes, number one, it takes that role off of the MD or PhD who's conferring the diagnosis and allows them to focus on, let me be present with you as a family, let me walk you through this feedback session, and then like a warm or soft handoff to someone else who can support the family afterwards. And the notion had always been like, let's not just like be a one-stop shop. It's like also have continued contact afterwards to help that family navigate whatever systems of care come afterwards. The irony is when we do like our patient engagement surveys, our family navigator consistently scores above the psychologist in terms of what the families find the most important and most useful part of their experience. The family navigation always scores high. Of course, you have to have really good ones. So I have always been a fan of family navigation and patient navigation, and did a deeper dive a couple months ago and came across this group of people who are going to talk to you who've done amazing research in the area and actually published papers on family navigation in autism and what it does and how it works and how you might be able to implement it in your own system. My argument would be, as a fiscally responsible adjunct to your service that provides the most amazing bang for your buck in terms of patient experience, you can't do anything better than family navigation. One caveat that I have before I pass it over to Melissa is you got to be really careful, because what we've dealt with here is, I mean, I have my family navigators here are so good that outside agencies call them that have nothing to do with us just to get resources and support. They're that knowledgeable about the content area. And it's more than just handing off a list of names. It's actually helping with interpreters, helping the families walk through the forms. So it really is supporting the families in a bigger way. But what we found you have to be really careful with is not letting it bleed into case management. And I don't know if they're going to address that today, because you can have social workers that do case management typically, and that's they carry a caseload of 10 to 50 patients or whatever. This isn't that. So what we've had to do here, and I see Danielle on, hi Danielle, is we created a tiered system where our providers will say, oh, this is a tier 1 family navigation, a tier 2. The higher the tier is, meaning we need more support and navigation for this family. And then we have some fences and guideposts around that. How many times would they contact the family? How much help does it? Because we don't want it to become case management, but we wanted to have, it was a way for the provider also to communicate to the family navigator their sense of need, saying, yeah, this is a tier 1. They only need this, this, and that, right? Of course, that can change once the family navigator engages, but it puts some, so we can actually talk more about that if people have questions too about how that tiered system might work, because we found we really need to put those guideposts on. But so I'm really excited because, like I said, family navigation is huge. I think every place should have one. I think every family should have it. So with that, like, incredible high bar now, Melissa, I'm going to pass it over to you, and feel free to introduce yourself and kind of let us know. So thank you, guys.
Yeah, great. Thank you for this great introduction. So some of the work we're going to be chatting about today, I'm going to go ahead and share my screen. Pull this up. Hold on. Let me pull this. All right. So today I'm here. I'm Melissa Maye. I'm a system scientist.
We're seeing
sorry.
Yeah, just switch your view on the display settings to the, if you go to display settings, we're seeing your notes slides. So
Oh, great. Okay, 1 second.
I think if you just went up to the display settings, it has a switch option. That's what I've had to do. So
Oh, it does. Okay. Let's see. Does that work?
yes, perfect.
Okay, great. Okay, so I'm Melissa May. I'm assistant scientist at Henry Ford Health, dually appointed through MSU as an assistant professor of research as part of the Henry Ford Health and Michigan State University Health Sciences partnership. And I'll be talking a little bit today about the increase of or the inspiration of family navigation at all processes, from screening through access of, first diagnosis. And then we'll be handing it off to hear a little bit more about family navigation after diagnosis. My work, I've been describing it as family navigation adjacent. It's definitely been inspired by the work in family navigation, but was pulled more from, an initial acknowledgement that we are missing some steps in the pipeline of universal screening through the referral, through connecting to even the evaluation, and connecting families to early intervention ahead of, connecting with the evaluation team, what is often during, long wait lists spanning 3 months if you're in a really good position, in a really good place, up until even a year still in some areas, both in Michigan and obviously nationally. So today I'll be talking a little bit about how we're working at Henry Ford Health to increase access, accuracy, and equity of universal screening for autism spectrum disorder. Increasing access to, a prompt referral and supporting families kind of during all of those different gaps, and connecting them to early intervention through IDA Part C in the community in the meantime. Okay, let's see. No, my slides aren't. Okay, there we go. So as many of us know, this is going to be a quick and dirty review of a lot of information we know, but really sets the stage for what we're doing at Henry Ford Health and how we were inspired to develop our implementation study. So at Henry Ford Health, I work primarily with the medical director of the Autism Center here. And since, my hire in 2019, we have been talking a lot about that screen refer process and connecting families to services ahead of diagnosis. There's a lot of statistics out there, some of them, but most come back and say that a large number of children are identified as having at least one developmental delay, whether that be a social communication delay, a communication delay, a physical delay. And then of those 16% of children, approximately 3% of them will meet criteria for an autism diagnosis. It's well known that early intervention has been associated with skill development across numerous outcomes. And then also that in many states, including Michigan, there's a child find mandate to kind of identify all of these children that have one or more developmental delays to provide them with that early intervention. And currently it's not being met here. And then but it's also well known that identification of developmental delay, including autism before age 3, permits access to those free IDA Part C early intervention services. And also that the Academy of Pediatrics recommends screening for autism at that 18 and 24-month well-child visit with appropriate referrals being made, and not just to, for a full autism evaluation, but also referrals to audiology, to speech, and to early on. As we know from the large health system, assessments of universal screening for autism, we've seen dramatic increases in screening rates since the American Academy of Pediatrics made this mandate, some up to 90% for a one-time screen between that 18 and 24-month child visit period. However, even with those really high screening rates, we've seen documented disparities across race, ethnicity, income, and language, and other sociodemographic factors, kind of indicating that minoritized children are not being screened as often, despite a high increase in rates. One thing that has also been consistent across these studies is we noticed that referral rates for autism and early intervention have remained quite low across all children. So even in health systems where it's been documented that universal screening rates are quite high, referral rates are quite low or different than those high screening rates. And then oftentimes referral rates are not matching. If you're screen positive, are you being referred kind of automatically, as an evidence like based indicator would suggest. So in thinking about that and knowing that of the children who are screened with MCHAT-R, which is one of the most commonly used screening tools in health systems, the 92% of children who screen positive on the MCHAT also qualify for free early intervention through IDA Part C in Michigan. That's called Early On. We thought that this was a pretty great opportunity to work to identify an implementation strategy that addresses, both provider, system, and patient barriers to increase access to screening, referrals, and early intervention ahead of that full evaluation. Just to give you a little bit of background information before jumping into what that strategy, what the barriers we uncovered were, and what those strategies are that we're currently piloting at through a Michigan Health Endowment Fund grant, are that we in 2017 had really low documented screening rates, as they were all administered via paper and pencil. So I extracted data through an electronic health record extraction using a language analysis, as well as looking at factors that we could easily extract, that are more in variables form, for those of you familiar with EHR data extraction. And so it was quite low in 2017. In 2017, near the end, is when Henry Ford Health implemented their electronic administration of the MCHAT. So like many other health systems, electronic administration meant both the patients were filling it out either ahead of time at home through a patient portal or an online website before we had MyChart up and running for everybody, or in person on the computer at the visit. Over time, and that electronic administration also included automatic scoring. So just very consistent, if you're familiar with other health system implementations of electronic universal screening. We saw, a pretty linear increase over time, a little, COVID delineation from our line of best fit. And then in 2021, our providers at Henry Ford, along with leadership, implemented kind of a really cool natural implementation strategy of a standardized physician note that we call the express lane. So clinicians at Henry Ford up until then had a lot of independence in how they developed and used their clinical notes for well-child visits. And then in 2021, they rolled out a formal standardized note that they encourage physicians to adopt. Many physicians did choose to adopt this standardized process with the express lane, but not all. And we saw this nice little boost even during COVID in our screening, and a large increase in well-child visit completion rates of MCHAT-Rs. However, there was still a lot of variation across clinics. So I redacted clinic names for our presentation, but you can see that there's like a pretty large range in performance despite high overall averages. So working with my clinical partners, what we realized is that even though our rates at well-child visits were very much improving, that there was still a lot of variation at individual clinics, such that, and patients at these two clinics, despite a pretty high volume of 18 and 24 months coming through their clinics, we're not getting the same care, the same screening as the patients over here. So we worked together to identify all the different barriers that we could based on this initial data pull, as well as kind of thinking through our existing process and examining that standardized clinic note or the express lane, and work to identify barriers to screening, referrals both to the Autism Center for a visit, as well as referrals to early intervention. And we also considered all equity factors that may impact screening, as well as that transition period between getting that referral from your provider and making it to the visit, which is like another big gap area for our health system. So I'll just go through these together with you. So for at the screening level, the MCHR needs to be completed by the parent, right? So it's the parent screening tool. Not all parent, and right now it's rolled out 7 days ahead of the visit to parents to complete ahead of time by MyChart, but not all parents have downloaded MyChart, and not all parents use these screening tools. Epicare, which is still an option in the clinic. So families can come to the clinic and then the provider, like an MA, can log a patient into the computer and complete the MChat that way at the day of visit. And that's great. But it also requires substantial time commitment, meaning like the parent needs to either get there early or it's cutting into their scheduled 20-minute visit with the provider when they still have many other things to cover during that time. You need a clean room available and a computer availability. So some of our computers are rolling in and out of rooms now. And so there's not always a computer in every room there. So there's a substantial set of barriers there. And then at the referral phase of the process, deciding to refer and make the referral, the current drop-down menu for that express lane, that standardized provider note, doesn't provide evidence-based referral guidance. So it is showing the provider that the patient is at a low, moderate, or high risk or higher likelihood for autism. But it is not indicating what the provider should do in the plan section. The plan section of this note, which has a little drop-down menu of like next steps, based on the MChat screen. But prior to our project, it didn't even include the Autism Center, actually. It was like referrals to behavioral health and referrals to social work. So that was a barrier, and supporting providers in making evidence-based decisions in terms of what to do next. The follow-up interview, which is the second component of the MChat screening tool, wasn't routinely administered to moderate risk patients. Physicians had access to this tool, but they weren't asked to complete it routinely. It was just an option if they felt like they needed it. And we know that using the follow-up interview does reduce false positives, and reducing false positives could actually help us reduce our wait list. So that was something we thought would be good to address. Then if the provider does refer to the Autism Center, and this is where family navigation especially comes in, the parent must call CAD or their community mental health clinic, depending on their type of insurance, meaning they also need to identify their community mental health clinic, or their provider needs to during that really time crunch well-child visit to initiate the evaluation. So in thinking about the parents and the stress level of hearing that you have a positive screen for further evaluation for autism, and kind of like the gap or the fall off. When examining our patient queues of referrals of who is following up, we saw that there was an enormous cliff, the hundreds and hundreds of patients that were referred but had not called to connect with the Autism Center, and the Autism Center had no protocol in place to connect to patients directly who were referred. And then finally, equity. So the MChat was only available in English at Henry Ford, despite having a large Spanish and Arabic speaking. Some measurement concerns, even though 6th grade reading level is, considered to be pretty great for our, creating these types of measures overall. There are some families within our patient population who this still might be difficult for, and that additionally, one thing that we're still working on and is an interesting EHR challenge that I'll kind of like save time on and kind of skip over today, but I would love to talk with anyone about in more detail later, is that EHR data extraction presents a really interesting way of like different ways of pulling the data. So we don't know whether or not additional disparities existed pre-implementation, pre-identifying these, our implementation strategy. But we erred on the side of how can we make this, how can we develop this implementation strategy in a way that anticipates any other types of known disparities that would prevent a family from being able to move through the process of, screen referral evaluation and connecting them earlier on to treatment. So what we did is that we altered the clinic workflow. So the appointment is still scheduled in the same way. The MCHR is assigned automatically by the scheduler if it was scheduled 7 days in advance. And then the parent completed the MCHR. So one way that we've altered this is that we've incorporated iPads into the waiting room, so that a patient room doesn't need to be available. Like cleaning an iPad's much faster than cleaning a whole room, and patients would be able to complete this in the waiting room while they're waiting for their visit, and then bring the iPad into the room if they're late for the visit, or if for whatever reason. Another thing that we were able to do with this iPad app was to incorporate Spanish and Arabic, which was a great workaround because our patient portal MyChart did not allow us to put Spanish and Arabic in their welcome app. For those of you who are familiar with this type of workflow, because MyChart and wasn't wholly available in Spanish and Arabic. So that was a really great strategy that we used, and we were able to connect everything into our patient EHR the same way. And then this is where it becomes very relevant for like family navigation and support, is that we are task shifting our provider workflow and reducing the time barrier on them, and off shifting some tasks that were traditionally thought to be assumed to be completed by the provider onto a person in our clinic at the autism center, who is either a social worker or a licensed master's level psychologist. So if the child is at risk for autism, this is a little snippet of their standardized note. The MCHAT score pops up and the risk level pops up. That was already there from the original standardized note. And yes and no risk for autism is right here. Again, that was already there, but they had to click it, which is a behavioral economics component. Focus less on that today, but more on the navigation support. Is that in the plan section, they're allowed to then click reviewed, no referral necessary, low risk patient. So the evidence-based practice is embedded here, or reviewed, CAD referral made, moderate or high risk patient. In order to support and promote clinical decision-making, we also have review concerns addressed, but require them to like enter in what those concerns were and how they were addressed as the wild card. Like if a child is very medically complex, and so it's not appropriate to refer to the autism center because maybe they were flagged for the MCHAT, but it's clear that they're flagged for the MCHAT due to a physical difference or physical developmental delay or something like that. So one thing we did to support our providers is move and do task shifting to this person at CAD. So this person at CAD is new. It is in our case, a licensed master's level social worker. Licensed master's level social worker, who then receives all of these referrals from the provider. So we're hoping to increase referrals by like putting this into their drop-down menu in their standardized notes so that there's a clear indication of what they do next. And then that person, for children who score in the moderate range on the MCHAT will complete the follow-up interview and then do appropriate follow-up care with the patient at that time. So if the child continues to screen positive on the MCHAT following the follow-up interview, that social worker will then offer the parent the option to schedule either with our autism center, or if they have Medicaid, with the appropriate community mental health provider in their area. And in Michigan, the gold standard for patients with Medicaid is that the referring provider will do a warm handoff. So our social worker will then also get permission from the family to complete the warm handoff, call the community mental health center, talk to them, provide them with all the necessary information, and connect that family there. And if they are able to be seen through our autism center, then the licensed social worker then provides them with all of our paperwork, follows up with them on the paperwork to make sure that it's completed. And then once it is completed, that person then coordinates with our scheduling team to ensure that this patient is making it into our patient queue, and into and will be scheduled upon parent completion of that paperwork. So we have these supports at this junction of like, we've gotten you through the screening process. We know that there's this big gap or this big cliff between, oh, your provider's made the referral and now what? And then our licensed social worker is stepping in to kind of support families in making it through that gap period. Additionally, if the child continues to screen positive on the MCHAT following the follow-up interview, this licensed social worker also provides parents supports in completing their referral to early on within their community, and assures that they'll then be seen by early on, almost always ahead of their evaluation. So kind of getting them set up with access to early intervention to support them in whatever way possible, even while we're working through that, often stress producing experience of, waiting to see, like, I have this referral, my provider is worried about autism, and now I have, oh my gosh, a 3 or 6 month waiting list. Now what do I do? So that person is conceptualized as the one to kind of help them navigate through this experience of between referral and evaluation. If the child scores in the high risk level, and I know I'm using like risk language is what the MCHAT uses. Personally, I definitely support higher likelihood for autism on the MCHAT-R, then the social worker will then proceed, in the way they would for a child who continued to screen positive on the MCHAT following the follow-up interview. So they would then do the same thing with providing patients with paperwork support to be seen at CAD, our autism center, or to their appropriate community mental health provider, and of course provide the same opportunities to connect families to early on in their area to initiate services ahead of that visit. So this is, I think, been a really like powerful, I think, shift. We just launched and have in May and have already supported a couple of families through this process. So far it's going really well. I've been doing a little sneaking and tracking, and I see that families are moving very quickly with the support of our social worker from referral and through completing their paperwork. And all families so far have accepted our warm handoff either to community mental health or to early on intervention. So hopefully we're connecting families in a timely way too. So that's where we are at with, oops, you guys can see all of this. That's where we're at right now with our current pilot launching, and we're really excited about analyzing the data to see if families are indeed moving through this stream, if they're connecting with early intervention services more sooner, and kind of also analyzing how that process is working in terms of drop-offs for referral from provider, and then also speed of accessing that evaluation. So now I think we're going to hear a lot more about what happens next after you get that diagnosis and have made it there in terms of family navigation. Though I do see that there is a couple questions on the side here.
Melissa, let me jump in and say, first of all, thank you. Like what you just gave us was exactly why, in the spirit of this idea workshop, which is, we need actual practical tools that we all can actually implement at our sites. Every context is different, but some of your ideas about the flow, I think, are super important, and depending on context, can be implemented in different ways. I was hoping that while I'll say hi to Emily and Andrea, and they can take over, but if you could address this really good question and chat about like how do you do this? Who pays for it? That kind of stuff. If you can address those, but also I'm gonna put you on the spot here. It's really I'd love to see like your workflow in like a workflow kind of arrow chart thing. And I don't know if you have that, but if you have that and would be able to post that on the Ideal listserv, it just make it really accessible for us to go, oh, I see what you're doing here, here, and here, and the flow and the arrows. That would be amazing. I don't know if you have that, but if you do, that'd be great to post it that we can actually access and bring to our folks to say, can you do this in our Epic or whatever system you're using as well? So yeah.
Yeah. I have different variations of it. I will definitely see what I can post in the next week or so.
Okay, thank you so much. Thank you.
And then in terms of the cost part of it, thank you for bringing that up. It's something I forgot to mention. So we conceptualize this entire implementation strategy from a sustainability vantage point, which is why we're doing it like in such a partnered way. We are partnering with our billing department to see if we can get the follow-up interview to be reimbursable.
Nice.
So
Yeah.
far with our specific payers, they don't see a problem with it, which is great news, because in the past, when I've been working in different contexts, where people had been administering the follow-up interview, I'd always ask that question. I'd be like, well, can we pay for the follow-up interview and have like somebody else do it? And everyone was like, no. But then here, for whatever reason, within this context, and I really do think it's context and insurance provider specific, we're going to be using the same CPT billing codes as the MChat, and enforce it with and to see if it continues to be accepted as a billable service, which would pay then, is what we're also we're collecting cost effectiveness data to see if billing for the 1 hour of the MChat follow-up interview would cover how much of
Yeah.
all of the workflow associated with that. So that's part of, we're collecting this data, like this is like a pilot, and I'm hoping to test this in an RO1 is a next step. But right now we're looking at like acceptability, feasibility, appropriateness of this implementation strategy within this context, and then also collecting preliminary cost effectiveness data just to see how sustainable having that social worker or that or a licensed master's level psychologist or a different type of person would be ensuring that once the grant money goes away, we can still have this person in place.
Well, again, we only ask that you can't tease us with this and then like not give us any backup. So on the on our list, or feel free to post kind of what you found. People, I'm sure, will be very interested. But all right,
Yeah,
Emily,
absolutely. And I
and
think that one thing I've really learned since being embedded in a health system is how important relationships are between the health system and the payers, and that those relationships go far longer and than any relation. Like, I'm sorry, the relationships go longer than the data. And I was like just
yes,
shocked to notice that. So developing great relationships and partnerships
so
with
important.
insurance payers is a great thing.
It
Yeah.
can have huge payoffs, no pun intended. Um, Emily and Andrea, let me pass it over to you. We have about 23 minutes left, so I want to give you a heads up. Yeah, so take on over.
Great. So I will quickly introduce myself. My name is Andrea Chu. I am the Director of Programs and Operations at the Hassenfeld Institute at Brown University, and I served as the project manager in Boston, where the study that we will be talking about actually took place. Emily, do you quickly want to introduce yourself?
Sure. I'm Emily Feinberg. I was the PI on Project Early that we'll be talking about. And I am a faculty member at the Hassenfeld Child Health Institute and at Brown University School of Public Health.
So first of all, thank you so much, Melissa, for such a great presentation, and Dr. Kane for having us here. So today we're going to be talking about sorry, I'm moving people across the screen so I can see better. So today we're going to be talking about family navigation in the context of autism, from screening all the way until engagement with services. And we are going to be presenting findings from our research study that we referred to as Project Early. And so this project actually started almost 10 years ago. So putting together this presentation was kind of a walk down memory lane, a little bit of a blast from the past. So first of all, no financial relationships or conflicts of interest to disclose. So Project Early stands for Engagement, Assessment, Referral, and Linkage for Young Children. And the project really stemmed from a funding opportunity back in 2013 that NAMH put forward to support research that develops and tested service system interventions that would rapidly engage young kids at risk for autism in evidence-based treatments. And so out of this funding opportunity, 5 research projects across the country were actually awarded RO1 funding to test these different system innovations. And all were designed with the same goal of improving access to early screening, diagnosis, and engagement in services. And so these 5 studies were all being conducted in a variety of different community settings or primary care, as was ours. And you can kind of see where the other studies were at. So Project Early is a hybrid comparative effectiveness trial to assess the superiority of a family navigation intervention compared to traditional care management as a means to shorten the time to diagnosis among children who are considered at risk for autism. shorten the time to deployment of autism services among those diagnosed, and improve engagement with autism services. And as part of the study, we also conducted an implementation analysis, but we are predominantly focusing on the main outcomes for this presentation. So Project Early was really a multi-site study that occurred across 3 large urban primary care networks that serve diverse low-income children. And so each network was affiliated with an academic medical center that was a member of the HRSA-funded Developmental and Behavioral Research Network. And so this was really important for us doing the study because the settings really represented the diversity of settings where low-income urban children typically receive their care. So for the study, we recruited 15 to 27-month-old children who were identified as being at risk for autism in pediatric primary care. Our research staff actually had access to the EMR, and we recruited children who screened positive on the MCHAT-R in their pediatrician's office, or children for whom their PCP had a clinical concern for autism and were also being referred for an autism evaluation. So we were able to see those referrals to the DBB clinic for an evaluation come through. Our staff would re-administer the MCHAT-R and do the follow-up interview when appropriate based on the scoring guidelines, just as a way to ensure consistency across the sites, and also because we really knew that the follow-up interview wasn't really being done at the pediatrician's office. We implemented a loop-back procedure to inform the referring provider of the results of the repeated screen. And so children who screened positive on the repeated screen were invited to enroll in the study, and those who had a negative screen, but for whom the provider still indicated a clinical concern for autism, were also invited to participate in the study. Children who already had an autism diagnosis and who were in custody of Child Protective Services were excluded from the study, and no families were excluded based on language. So in the study, the families, again, were randomized to receive the intervention, family navigation, or receive care management. So a little bit about family navigation. There's many ways to think about it and to implement it. So the way that we thought about it is, ultimately family navigation is rooted in the chronic care model, and it really shares some similarities with patient navigation, which has its roots in cancer care. And patient navigation is time limited, so it provides care from the time of screening to engagement in services. However, unlike patient navigation, family navigation really takes into account the entire family unit and typically uses community health workers. And so the navigators in the study all followed a manualized protocol that had 3 core in-person visits that they had to meet with the family. And the navigators were all bilingual, bicultural. And I will get into the details of the family navigation arm in more depth on the next slide. Families in the care management arm, they received an introductory phone call from the care manager, who also typically was bilingual, bicultural, during which the care managers reminded the families about their upcoming DBP intake appointment. They offered to answer any questions that the family may have, and they provided resources to community services to address social needs. So if the family was not reached by the care manager at the time, then we would mail a letter to the family introducing the care manager role. The care managers were only available by phone and clinic-based, so they could not go out into the community to meet with families in their homes or in other settings, a difference between them and the family navigators. However, both family navigators and care managers had their own phone lines, so they could communicate directly with the families or have a direct line for the families to reach them. However, for the care management arm, any subsequent contacts beyond that first introductory phone call made by the care manager had to be initiated by the family. And so this is just a little bit more about the family navigation arm. So as previously mentioned, there were largely bachelor's level bilingual bicultural members of the community. They were meant to support family from the time of a positive screen all the way through engagement with services. Navigators had 3 core visits. that they needed to complete with the family at key time points during this process. So the first visit would happen after the referral to the DBP clinic, so after the screening results. The second visit would typically happen after families received the diagnosis, and the third or closeout visit, so to speak, happened 100 days after families received their diagnosis. The navigators followed a manual that detailed steps that should be completed along the process, and you can kind of see snippets here of what that looked like. Additional in-person or other contacts were allowed, and the navigators again had cell phones to facilitate communication with the families. Some navigators, as I mentioned, they were allowed to go out into the community to visit with families at their homes or elsewhere. So some of the navigators were actually accompanying families to their DBP appointments or to their IEP meetings with schools. As part of the training, the navigators completed a 4-day pretty intensive workshop on shared decision-making and motivational interviewing. They also received training on, the basics of autism, what autism is, just to really facilitate, them being comfortable having some of these conversations with families. And that training on autism was given by our DBP clinician. We had yearly booster trainings for all navigators, and they also participated in monthly and individual supervision meetings. These meetings were attended by all of the project managers, as well as the lead navigator in Boston, who kind of helps supervise the navigators across sites. The navigators also logged each contact that they had with the families, including the type of contact, whether it was in person, over the phone, the time spent, and the issues addressed during those contacts. And to assess fidelity to the intervention, 20% of the sessions between family navigators and the families were actually audio recorded. So in terms of our study outcomes, we conducted an intent to treat analyses. Our primary outcome here was diagnostic interval, the number of days to diagnostic resolution, and as well as time to engagement in autism services. We also collected patient-centered outcomes throughout 4 different time points in the study, primarily utilizing measures looking at social support and family stress, as well as parental and family functioning. And then we also collected additional data, had some core autism measures that were shared across all of the 5 studies that were funded under this mechanism. So we conducted ADOS, the ABAS, the Mullen, and the Vineland as well. And we followed up the families over 3 time points post-baseline, and were able to maintain an 87% follow-up rate, of which we were really extremely proud of our team for that. So for our analyses, we did an intent to treat analyses. We also did Kaplan-Meier curves to assess time to diagnostic ascertainment. We also did hazard ratios to estimate differences in the likelihood to achieve diagnostic resolution between study conditions. And we also included a clustering variable to account for site differences. So a little bit about our patient demographics. I'm trying to keep an eye on the time. So I'll go quickly over this. So the sample was very racially and ethnically diverse, with approximately 30% identifying as Hispanic Latino, almost 40% living outside of the United States, being born outside of the United States, and almost 20% speaking a first language that was not English. And as you can see, a little over 80% were on Medicaid. In terms of the children, the average age at the time of enrollment was 21 months, and the sample was primarily male, and a little less than half were already receiving EI at the time of enrollment. This is just our concert diagram. The main reasons why families declined to be in the study was primarily because they didn't feel that they needed additional support. And then this is just some data in terms of our fidelity to navigation. So 80% of the families received the 3 core in-person visits. 72% met visit content fidelity. So we listened to the recordings and kind of calculated fidelity to the motivational interviewing skills that the navigators were trained on. And prior to receiving a diagnosis, almost 93% of families had at least one face-to-face interaction with the the family navigators. And on the right side, you can just see kind of an average of the different contacts. And now I will turn it to Emily. Emily, do you want me to stop sharing? Emily, you're muted.
Yes, please.
You want me to stop sharing?
Yes.
Okay.
One second. Second. Just have to find my slideshow. Okay, can you see okay now?
Yep, that looks good.
Okay, so this will be a bit of a whirlwind. This is the first Kaplan-Meier curve of our primary diagnosis, which was time to diagnosis and includes all sites. And as you can see, just to orient you to this graph and the next series, the time to diagnostic assessment is in days on the horizontal axis. The proportion who achieve diagnostic ascertainment is on the vertical axis, and we've labeled the two arms, family navigation in the gray and the care management arm in the orange. And what you can see is that the family navigation arm was significantly more likely to complete diagnostic ascertainment. The adjusted hazard ratio, as you can see, is 1.39. And if you look at the numbers, that was 86% in the family navigation arm versus 76% in the care management arm, completed diagnostic ascertainment by a year period. And you can see the percentages that were diagnosed with autism versus another developmental diagnosis. I think what was most interesting in this study were some of the site differences. So we have the three sites, Philadelphia, Boston, and New Haven. And what you can see is that in Philadelphia, there really wasn't a difference between the two arms. And we're not exactly sure why that is. But you can see in Boston and New Haven, there was almost twice as the family navigation arm was more than twice as likely to achieve diagnostic ascertainment. And when we dug a little deeper, what we saw was that the intervention was really significantly more powerful among Hispanic families. And this is somewhat compounded by site also because the New Haven and Boston had high numbers of Hispanic participants, and the sample in Philadelphia was largely African American. And then the other part of the results that I would like to share has to do with time to EI engagement. This was it's always a secondary data analysis of the Project Early data. We used the same 11 primary care sites in the 3 states, but the sample was 156 participants. They were children who were enrolled in the main study and who had EI services available, EI service records available, and the child was not enrolled in EI at study enrollment. We used for this data, for this analysis, the service records from state agencies and early intervention agencies that were the service providers. The records include service date, type, setting, and duration. And what we were looking at was the time to EI service engagement, looking at it as the number of days from randomization. And also we looked at the intensity of services that families received. So, here's the consort diagram for this particular analysis. And you can see that we had some who were excluded because we could not get the records, and some because they were excluded because they were already enrolled in EI. Sorry, so this is the Kaplan-Meier plot looking at the time to engagement in Part C EI services by treatment group. The key takeaways here were that 33% of children in the family navigation group and 18% and 26% in the care management group had initiated EI services. You can see that when you look at the graph, that for the first 50 days, there really isn't much difference, and that the splitting starts to happen at around 50 days, which makes total sense since the process of EI allows 45 days from initial referral until the EI assessment is completed. So we see that's this splitting start to happen at around 50 days and continue over the amount of time that we follow the children. Just as I was sort of thinking about data, this was a really challenging data analysis. The data we got from EI agencies was incredibly messy and took a lot of work to sort out and make sense of. But we feel like it was kind of a data source that was really unique and as complete as one could get. So
Emily, just to really quickly interrupt, I'm glad you're we have about 2 or 3 minutes, so I wanted to make sure you're able to convey your.
So I'm going to skip there, and I just want to make one other comment. Just to summarize, we were really pleased with the overall studies of our finding, and to demonstrate that you really can recruit a quite diverse sample from structurally marginalized communities and engage them in a rigorous trial. And just to think about, well, I want to thank our team. These are our navigators. And to think about where we are going with our work, which is really integrating navigation into primary care at the point where children are screened as a way to really think about autism as, in sort of more broadly as a quite common at this point behavioral health condition that needs to be addressed in primary care. And if people have questions about that, I
have a quick one. If people were hoping to, and if you can unshare your screen for us, if people were hoping to use this model / train up family navigators, what would you recommend? Is there like a specific way that you train up family navigators?
Well, I think our manuals were really, well, let me back up. I think the first thing is develop a workflow that talks about the family navigator role, that sort of depicts the family navigator role within the larger workflow from screening to diagnosis and beyond. And I think our manuals were really helpful in the training in terms of guiding sort of the actual steps that navigators should be doing, as well as I think teaching some of the basic content that included not only information about autism, but also motivational interviewing and approaches to shared decision-making and problem solving.
And I think I've downloaded, that manual is a free download, if I remember right, isn't it? So.
We are figuring out how to make the manuals downloadable at this time. It just has to do with we want them to be publicly available, and they will be, but we also want to track how people are using them. So we're just working on the logistics of that now.
Okay. Well, I see we're at time. We're at noon here on the East Coast. So Emily, Andrea, and Melissa, thank you so much for the information and knowledge. I know that this was not last minute, but pretty close to last minute, get you guys to come present. I think it's hugely important for the field to recognize the role of family navigation. And I appreciate the work you guys are doing to actually publish data to show that, no, it really is effective. It's not just something that the patients like, but it actually does work. So thank you so much. And we look forward to more of your publications coming out. So thank you all. And we'll see you next month when William Mandy presents on eating disorders in autistic women. So thank you, everybody. See you next month.